Masitinib is a first-class oral tyrosine kinase inhibitor for severe asthma. Masitinib targets mast cells that we all know that are an important cells involved in the mechanism of asthma. And by inhibited mast cells activity, inhibit c-KIT, lin, fin kinase, and also it's a potent inhibitor of PDGFR. These are pro-inflammatory mediators and also involved in airway smooth muscle cell function that contribute to hyperresponsibility in asthma. So mast cells remain a main type of cells involved in inflammation in asthmatic patients, and targeting these mast cells, masitinib could be a useful option, especially for the severe asthmatic patient that we have no other option. The study AB07015 was a long study and evaluated the efficacy and safety of masitinib in severe asthma uncontrolled with high dose of inhaled corticosteroids plus LABA plus oral corticosteroids. So most severe patients, they are on oral corticosteroids, and this is important. And the selection of the population was the population with high dose of eosinophils, but also population with low dose of eosinophil, because practically in this moment we have this gray zone of low number of eosinophil in inflammation. And masitinib proved efficacy on controlling the symptoms, reducing exacerbation, improving lung function and quality of life on both category of patients. The subgroup analysis was on patients with increased eosinophils, but overall population have a low number of eosinophil, and our cutoff point of eosinophils was 150 cells per millimeter cube due to the fact all the patient was on oral corticosteroids. The study starts with a running period of 2 weeks without a washout period. The patient are on the standard basics of the treatment with oral corticosteroids, and then one arm enroll masitinib, the group of patients with masitinib on the dose of 6 milligrams per kilo per day. The study treatment was the period of treatment of 36 weeks, with the possibility of continuing treatment after the study period. That's why a part of the patient was studied till 6 weeks. So all the study have a long period of subrogation of the patients, consider in terms of exacerbation, which was the main point of the study, in terms of efficacy and safety, controlling the symptoms, and spirometry, lung function test. In all these objectives, masitinib proved efficacy. And regarding the safety, the data shows that were insignificant difference between the placebo group of the patient and the group with masitinib. In the subgroup of the patient with high eosinophil level, we find out that the number of exacerbation reduction of exacerbation was even higher than in overall population of severe asthma. The reduction in overall population, independent of the eosinophil group, the reduction was 43%. And for the subgroup of eosinophilic patients, the reduction of exacerbation was 48%. A secondary analysis concentrate on particularly on the dose of oral corticosteroids used for the patient, and they find out that the reduction of exacerbation was higher in the subgroup of patients with eosinophils and higher dose of oral corticosteroids normally consumed of corticosteroids. That means in much severe patients. Regarding the lung function, was significantly improved FEV1, forced expiratory volume in 4 seconds, and the quality of life of the patients and the symptom was measured by questionnaire. We use asthma control questionnaire and asthma quality of life questionnaire for asthma, so 2 questionnaires. And they both demonstrate significantly statistic improvements in symptoms and quality of life of the patients. After this study, AB07015, we have a study called AB14014, and this is a randomized study control phase 3 in using Masitinib for patients with high eosinophil levels. So we concentrate on this subgroup of patients with inflammation, eosinophilic inflammation, and high dose of inhaled corticosteroids. The plan is to enroll 350 patients. The continuation of the first study that I mentioned, the results was this: use Masitinib in the group of patients with high eosinophilic level. But generally talking, Masitinib could be a very good option for the patient that are not allergic, they are not having eosinophil increase inflammation, they are not properly for biologic therapy. According to the guidelines, we have a few options of biologic therapy, but only the indication for the biological therapy in different of the product, I will not mention product, for the type of patient with allergy, known allergy, and increased value of EG and eosinophils. For the rest of the severe asthmatic patients, biologic therapy have no indication in this moment. So for this group that biologics are not targeted, Masitinib could be a good option. And in this study, Masitinib proved a good efficacy and safety, but also could be some indication, for example, in failure of biologics or associated with biologics in some subgroup of patients. We could use it in a few subgroups that we don't have quite yet medication in this moment, but it's have the advantage that it's an oral therapy. We know that biologics are not available on the country. For example, in my country, only 2 biologics available. And there are some cases at limits, and I will present the case. I have a severe asthmatic female, young, 45 years old, which is on a standard basic therapy, uncontrolled. His dyspneic, his coughing, the lung function is low. The control of symptoms was not obtained. I add oral corticosteroid as the last step, and I try to evaluate her for biologics. no EJ value was normal, no allergy proved. So one of the options I excluded, the first option for allergic patients, and the number of eosinophil per millimeter cube is at limit 280. What should I do? According to the guidance and to the standard and indication of biologics, I cannot use it only when my patient have 300 eosinophil per millimeter cube. It's still uncontrolled. For example, this could be an elective subgroup of patients that doesn't reach the number of eosinophils, so have some eosinophil involved in inflammation, but not the number needed to put it on biologics. So I think this could be a good option for severe asthma, uncontrolled with the rest of the therapy, and especially for the subgroup that doesn't prove the cutoff of eosinophil needed for starting a biological therapy.